hour. Welcome to session number 11 of our COVID-19 series, a series which we have dedicated to diagnostics for the pandemic. My name is Anafi Mataka. I'm from ASLM, where I play a dual role of project manager for the Laboratory Systems Strengthening Community of Practice, funded by the Bill and Melinda Gates Foundation, as well as leading our efforts in accelerating an introduction of innovative diagnostics within the national diagnostic programs funded by UNITAID. I'm delighted to be your moderator today. We are looking at an important subject of procurement and supply chain management. In nearly every African country, as well as many beyond the continent, we have had complaints that we are not testing enough and therefore missing many persons with COVID-19. Hence, nearly all of us are testing, scaling up testing. So more and more of this expanded testing has not only led to shortages of reagents and ancillary consumables, but it has also included other things like PPE, and many of you would realize that something like masks are becoming a very scarce commodity as countries look to ease down lockdowns and reopen their economies. We have also had concerns that many low and medium income countries are at the mercy of powerful nations when it comes to sourcing all these important diagnostics and related supplies. These concerns have been raised, but we also know that there's a lot of work that has been done by the Diagnostic Consortium to address this. To help us tackle this important issue, we have two high-profile presenters today. We have Dr. Yenew Kebede, who is the head of laboratory services at the Africa Centers for Disease Control and Prevention, as well as Dr. Lara Vojnov from the WHO HQ in Geneva, who is the Diagnostic Advisor in the HIV and Hepatitis Department, but like many of us, has also been repurposed to fight this pandemic. We shall start with a presentation from Dr. Yenew. But before we start, a few logistics. This will be a 1-hour session. And after that, we shall have questions and answers being responded to. Please use the chat box to enter your comments and questions as we move ahead with the presentation. Let me call upon Dr. Yenew to take us through the first presentation. Over to you, Dr. Yenew.
Okay, thank you, Anafi. Thank you really for coordinating this session. And I really would like to appreciate ASLM's effort to really, facilitate key sessions that can help, to give more information for member states and the laboratory community. So this is part of a series of webinars that we are organizing with ASLM and other partners. So I would like to appreciate you before I start with my presentation. So good afternoon, good morning, colleagues, wherever you are. Today's presentation and today's session is really touching a very important point, which is a major challenge for many of member states struggling with COVID-19 response. So let me start by saying, why more testing is important. So in the absence of vaccine and specific treatment, immediate identification and isolation of cases, and tracing and quarantine of contacts is the most important strategy to contain or slow the progression of this pandemic. Therefore, widespread but informed testing strategy at the early phase of the pandemic is very, very key. I'm not saying, you know, testing for the sake of testing, but it has to be geared to identify and isolate case and trace contacts. So I see some gaps in many of country responses, that you do more testing, but we are weak in terms of contact tracing and isolation of cases. So people generally, when I see, you know, the different writings, people generally are focused too much on number of tests per million, but this can be a proxy indicator for your testing program. However, without considering positivity rate, it may be misleading, because, you know, it doesn't mean that a country doing more testing is effective unless they are also identifying more cases, because it's clear that testing is not a vaccine. So generally, to assess the testing capacity in the continent, Africa CDC, and I also would like to acknowledge also CHAI has also done, you know, some equipment footprint analysis on manual RT-PCR, GeneXpert, and other automated platforms, including Abbott, Roche, and others. So based on that assessment, we know the continent can do 45 million tests in a year. But this is not without, this is not including, this doesn't include the private sector, veterinary lab, research, or academic institutions. So if you add those institutions, so we can add additional 20 million tests, and therefore, the private institution and other sectors combined with the public sector can generate, can do more than 65 million tests. However, some of the equipments, as you know, they are dual purpose. They are also used for HIV and TB programs. Therefore, we need to harmonize. If we consider that one into account, then 45 million tests will go into 35 million, and then a total of 55 million tests can be done in this continent without adding any equipment platform. But I see also, you know, many countries are adding additional equipments. We heard yesterday, Gabon is putting a high throughput, you know, laboratory through Chinese government support. So there are many other efforts. But safely, we can say, you know, 55 million tests can be done in this continent. And of course, this doesn't include antigen or antibody-based testing, which we lack guidance, but still countries are exercising. So what are the projected number of tests? If you see today, there are no really reliable modeling tools for the infection rate for COVID-19. And some of the models actually generated very outrageous numbers. If I take the WHO estimate for Africa, which they published after doing the study for 47 countries, the average, it says, you know, 29 to 44 million people will be infected in Africa. And then I can take the average of 36.5 million. And this actually doesn't consider the containment measures that countries are putting, mitigation policies. So some publications indicated that if mitigation policies are implemented properly, they may reduce the infection rate by 40%. Therefore, the 36.5 million will come down to 21.9 million. Based on the testing strategy currently recommended, we don't expect, you know, all suspected cases will go into laboratory testing. Especially, you know, at the late stage of the epidemic, you may not need to do testing of every individual. Testing really is important at early phase of the epidemic, but if it's widespread in the community, there is a possibility that you simply use case definition. We have seen that one in China, in France, Therefore, I'm expecting, only 60% of the 21.9 million people may need lab testing. And to identify 13.5 million, taking the maximum positivity rate of 15%, then the total projected test per annum for Africa will be around 87 million based on the WHO projection of the infection rate. I think these figures are open for discussion, but this is, the best guess that I can put at this point, going through, the different publications that are out there. So if we see the current progress where we are today, the continent has done around 1.62 million tests with a positivity rate of 5.7%. Actually, this is a 45% increase in the last 2 weeks, which is very, very encouraging. But as I said, all these tests have to be used for contact tracing. Therefore, I'm not sure, how much the continent is effective in terms of tracing each and every positive case, looking for contacts, and then really, implementing infection prevention measures and so on. I think our control measure will be judged based on what we do after the test result, but it's not based on what we are doing in terms of testing. So what are the supply chain challenges that we are facing? As Anafi mentioned in the introductory part, COVID is global pandemic, so there is really, fierce competition for commodities all over the world. If we see number one challenge, access for COVID-19 diagnostics is a very big challenge. As I speak now, more than 88 countries have put temporary export restriction on COVID-19 products, including diagnostics. Of course, some countries like Germany are lifting that restriction, but many countries still have restricted, the export of COVID-19 products. These are infection PPEs, laboratory diagnostics, and other commodities. So the second challenge is that supply usually is usually incomplete. For example, labs in Africa usually they rely on partner support or donations. An example is the Ethiopian Prime Minister and JACMA initiative provided support for 1.5 million tests, and Africa CDC has distributed more than 300,000 tests. WHO and others have also provided support. However, test kits provided by partners or from donations usually may not be complete to allow testing. When I say it's not complete, they could be either detection kits, they may not include, extraction kits, swabs, VTMs, and other necessary supplies. Other supplies for PCR labs, for example, plates, pipettes, pipette tips, test tubes, PPEs, and usually are not considered during this donation or support by partners. And then the third challenge is lack of forecasting and quantification at country level. Testing projections have to be done systematically at country level, and then all necessary supplies should be quantified. And these quantities can be used for pooled procurement at regional or continental level. They can also be used to present to partners or donors or finance ministers for funding. So, but the challenge is that from many countries, you don't get, really what you need for this response, except that, ad hoc requests that are coming now and then. I don't see, total country projections in terms of testing need and so on. That really is very, very important. And then quality of the product is also a big issue because, this is emergency. There are really many products that may not have been validated properly. Most of those are research use only authorization, or they are emergency use authorization, so are not usually independently validated. And then conducting systematic evaluation is also challenging because of lack of time or urgency to use the items. And then there is also, really, especially speaking to the African continent, lack of sufficient capacity to evaluate technologies quickly. Especially, this is true for many antibody and antigen-based tests that are coming. I think those are not, usually independently evaluated. So I think it will be important to really consider, quality while choosing any of the test kits. So another supply chain challenge that we faced is distribution. Once the products are here, we try to distribute. This is an example that my team has been really struggling with. For example, we wanted to deliver items to 29 member states. And out of those, around 22% delivery was possible after 10 days because of this country lockdown, closure of the airspaces and so on. And then between 4 to 10 days, only 30%, around 30% were delivered, 4 to 10 days. And then it's only 48% that we were able to deliver within 3 days. So this is really challenging. And you can imagine, if this requires a strong, cold chain temperature control. So it's really challenging to distribute commodities across the continent with this situation. So let me end up by putting some few recommendations. So our recommendation will be for member states to do projection of testing numbers per country, and then make quantification of all necessary supplies, not only PCR detection kits or extraction, but all the supplies, including the tips, adhesive tape, plates, and everything. And then we may try to do a pool procurement, as WHO is leading now, and through the request by heads of state at African Union, we are putting together a procurement platform that will be built within the African Union system. So demonstration of that tool was made last Sunday, and it will go live maybe after a week. So that really will be a very important mechanism for pool procurement. And then we want to also to engage member states to allow movement of cargo. We know there has been general restriction on movement of people, but movement of cargo should be allowed. And then when doing procurement, we advocate bundling, like detection kit, extraction kit, swabs, and VTMs to come together. Otherwise, if you bring one and leave the other, so it will not allow laboratories to do testing. So I think that's really a very important recommendation that we are putting. So I think those are my slides. I will be really happy, to answer some of the questions and get feedback from the audience as well. Over to you, Anafi.
Thank you, Yenew, for the presentation and overview of the great work that the Africa CDC is doing to lead the fight for this against this pandemic. I would like us to move over to the next presentation by Dr. Lara Vojnov, who will give us the global perspectives on procurement and supply of commodities. Over to you, Lara.
Great, thank you, Anafi. I'm sharing my screen now. Hopefully you can see it. So I just wanted to thank ASLM for providing the opportunity to present some of the perspectives and the efforts that we're trying to make at the WHO, but with a number of different partners, to be able to try to provide access to some of the tests. As Yenew has been describing very nicely, we've seen significant access challenges across a number of regions, of course, in Africa in particular, but also other countries that perhaps don't have the high market appeal of some of the other high-income countries. And so when we think about the WHO support that's gone into the COVID preparedness and response, there are a number of different documents as well as pillars that we've really been thinking about and trying to support countries across the globe. As you see in the middle here, we have a number within the strategic preparedness and response plan, a number of different pillars that are focused on some of the key challenges that we've observed within the pandemic. You can see in particular under surveillance and laboratories, a number of efforts that have been taken at WHO's level to try and support diagnostics across our member states. And in these efforts, effectively, we're trying to maintain, one of the key pieces is to maintain the essential health services that we've already been establishing for many years and ensure that we're meeting all of the health needs under the Global Humanitarian Response Plan. In the diagnostics pillar and the diagnostic space in particular, there have been a number of guidance documents that have come out over the last couple of months focused on supporting countries and thinking about the different types of testing that should be considered, the different patients or people to be looking to test, and Yenew touched on that quite nicely, sort of what's that prioritization might look like, as well as the testing strategy and some of the guidance documents around how to ship specimens within the pandemic. One of the key pieces here in the middle, as well as some of the thinking around the current technologies that are recommended for diagnosis at least, and how some of our thinking is looking to evolve when we think about rapid diagnostic tests. There's one key document as well, the second one here, and please see the website if you're looking if you haven't seen these already, which I'm sure you have, is around the laboratory biosafety guidance. And this is a recent document that came out just late last week that was really trying to indicate the biosafety standards that are required in order to do COVID testing. In the previous months, we perhaps provided relatively strict biosafety standards, and after some review of the evidence and data and information that exists, have been able to relax some of those standards to allow for more decentralized testing to be considered. Of course, there's also the emergency use listing that's provided now by the WHO. And through this, though it's not perhaps as robust as the pre-qualification process typically is that we know well, it's still a robust marker or mechanism to provide some guidance around some of the technologies that are available for procurement. And here we have, this is of course only updated up until last week, but they've been working quite feverishly to ensure that we're able to procure and have access to as many different types of tests as we can on the molecular side, as indicated here. Now, when we think about some of the different diagnostic recommendations that have been provided by the WHO, the primary recommendation is that we consider the use of nucleic acid testing or molecular testing to identify patients with COVID-19. As Yenew has touched on, we have several automated platforms that exist already, and a lot of these have already been implemented and used within HIV and tuberculosis programs, where effectively it's a sample in and result out. There are also a number of more manual open platforms that exist, and while they may take a little bit more human resource in order to operate, they do allow for greater access to test reagents and some flexibility in order to be a little bit more nimble if necessary, if test access is limited. As I said, some of the testing biosafety standards have been revised, and I think that's a very positive development in order to try and improve decentralization of testing. But of course, we want to keep thinking about some of the specimen handling and transportation needs that are required to ensure safety. When we think about rapid diagnostic tests, and I know that this has been a very hot topic in this forum as well as others, right now we don't recommend the use of antigen detecting rapid diagnostic tests for patient care, but we are very interested to look at the research into the performance, but also into the utility, and we're very much encouraging that from basic scientists as well as from the suppliers themselves and some of the programs and labs that could provide us some support in terms of the performance, and could see this as a potential advantage if we're able to answer some of these critical questions. Now, when we think about antibody detecting rapid diagnostics tests, again, currently at least, we don't recommend the use at this point for patient care. But again, we are encouraging the continuation of work to understand and to establish their usefulness in disease for surveillance, but also for epidemiological research, which is quite important. Because there are a number of key questions, particularly around the antibody issue, that we're really still trying to understand. These include whether antibodies, anti-COVID antibodies actually confer immunity to a next wave of infection, what the rates of seroconversion and whether antibodies are maintained in patients for long periods of time. And of course, when we think about using antibody detecting rapid tests, we have some concerns about how they could be implemented if used for diagnosis. And this is why we're still hesitant to recommend the use for patient care, is due to the inability to discriminate active from past infection, the potential for false negatives, and this could happen either early in infection before antibodies are developed, or potentially late in infection if antibodies have begun to wane quite early. There are some concerns about the potential performance of some of these assays at this stage, but also on the potential over-reliance of the test result rather than considering the clinical acumen or other key issues. We want to make sure that, though interpretation could be challenging, that we're able to provide the right information based on that test result. And at this stage, we feel like it's a little bit complicated or a little bit unclear what some of the results could mean for those patients as well as their contacts. Now, in thinking about the limited access to testing that we've seen thus far, and I'll focus mostly on the molecular side, molecular testing, given that's our primary recommendation, we have seen limited access to low and middle income countries in Africa, but also across all regions. And so we're really trying to work with partners like the Africa CDC and others to try and ensure that we can somehow increase access to testing. And we've started thinking about that, thinking about some of the consolidated demand. Of course, I highlighted some of the technical and planning guidance that has been published by WHO, as well as working with implementing partners and donors and national authorities. We've been looking at a series of different commodities. Of course, this platform now that we're on is focused specifically on diagnostics, but we're also trying to ensure access to PPE, to oxygen in clinical care, and then ideally, eventually, as they become available, to therapeutics, to drugs, and to vaccines. And essentially the effort that's being done by WHO and others is to come through with an understanding of the demand management and what the forecasting looks like across countries, and effectively consolidating that and coming up with some sort of principles in order to support how to allocate the limited supply to countries. Now, on the right-hand side with coordinated procurement, we're working with a number of different procurement bodies as well as partners to try and secure volumes in the market to go specifically to low and middle income countries. Ideally, we'll move towards price and volume price negotiation. At this stage, the focus has been primarily on volume and gaining access to tests. And then once these two key pillars come together, essentially the idea is to provide allocations based on the requests as well as the availability, and then distribute directly to countries to provide some access. I don't want to go into too much detail, but this is just a little bit of an overview of what we're thinking for the supply chain system, how countries can perhaps request and receive some of these volumes. And again, this is across, not just for diagnostics, but is across the different commodity pillars and consortium that have been developed. And again, it's about consolidating that demand, coordinating purchasing within countries, really understanding, what ideal volumes would you be looking for, who's able to provide that funding, and then through a streamlined distribution. As Yenew highlighted very nicely, there are challenges across the globe right now in terms of being able to distribute and provide any commodities given some of the different challenges that exist. And we're trying to think through with partners what some different avenues in order to ensure a streamlined distribution and supply Right now, there's a fair bit of work with the WFP, with the World Food Program, who are able to provide some of the logistical options that we have. As you can imagine, for the diagnostics piece, for those tests and commodities that require cold chain, we're also looking for some alternative solutions and working together with partners and others to ensure we're able to create a relatively streamlined distribution system. Now, in order to do that, as Anafi hinted at in the beginning of this webinar, the Diagnostics Consortium for COVID-19 has been developed. Like I said, there's also a consortium for PPE and another for the clinical care side. And this Diagnostics Consortium was developed and includes WHO, Global Fund, UNICEF, the Africa CDC, Gates Foundation, and others. And the goal of this consortium is really to, number one, to gather information and data on the tests that are in development, and to be able to work with those suppliers to negotiate access to tests, and then ideally, as well as lower prices. Of course, we're also working closely with the regions, with Africa CDC, to really understand what the demands are from countries, and really in order to support the negotiation for different test access. The role of the consortium is also to try and develop an equitable minimum volumes plan for distribution to all low and middle income countries, as well as small island states. And those small island states are in particular in the Latin American and Western Pacific regions. And effectively, or hopefully, we'll start to bring in additional technologies into the consortium as they become available and as we better understand their use cases. Now, my last slide, I just wanted to highlight some of the efforts from the consortium thus far in the ability for May alone to try and secure a minimum volume of almost 4.7 million tests. These again will be distributed across low and middle income countries. And while, you know, this is a really beneficial process and move forward, in the next 3 months, we're looking to procure over 15 million tests. Of course, countries can move forward and try and procure diagnostics through other avenues. And we don't, you know, we're not dissuading that. But what we're trying to do within the consortium is at least provide some minimum volumes to all low and middle income countries. We know that some countries have easier access to diagnostics and to PPE as well as clinical care. Some have more difficult access, and the consortium effectively is just really trying to provide an equitable minimum access across all countries. Of course, if countries don't want any of these tests, that's okay too, and we're coming through with plans to try and reallocate any of those additional volumes. So for this first period of 3 months, we have a few different types of tests that we have procured through the consortium. Looking at the Abbott, the Cepheid, and the Roche, which I believe a number of you know well through the HIV and tuberculosis programs. We have a couple of tests that can be used either manually, like the Thermo Fisher, or can also be used in an automated way. And then I really liked how Yenew highlighted one of the key pieces within procurement and thinking about how we can ensure bundling of tests. And there are a couple of tests that we're really focused on and thinking about that have extraction as well as amplification reagents together, and then sample collection kits. And of course, we want to ensure that we're able to procure enough sample collection kits as we are tests. Of course, I think we're really keen to ensure that we have country and regional feedback to understand whether these volumes hopefully can increase, particularly on the automated side, or whether these, you know, there's preference for other different types of tests that we can be thinking about to try and procure. But while, again, ensuring the operational considerations are as maximized as possible. And so with that, I believe that's all I have, and I just want to thank you all, and perhaps we can, back to you, Anafi.
Thanks, Lara, for the wonderful presentation. Colleagues, it's now time for questions and answers, and we will dive directly into a couple of questions that keep on coming. Please use the chat box to enter your questions. Try to send to everyone, since if they are sent to me privately, I may miss some of them, but there are colleagues who are helping pulling the questions from the chat. The first question is from Richard, who says, thanks for the presentation on this key challenge on the globe that we are facing globally, not only globally, but also on the continent as well. And he's looking at one of the mechanisms that has been employed to try and save the limited resources that we have, which he says consideration on specimen pooling in order to cope with the high demand. What is your comment on this? This has been a question that has been coming through. I'll let the presenters respond, and then we can also comment further.
Great.
Yenew, do you want to take that?
Yeah, I'm not sure. Yenew, do you want to take this? I know that with WHO thinking about pooling specimens, it is something that we're having conversations with internally. I know that there's a document that's being drafted to try and support and provide some guidance in terms of pooling. We've had this conversation in other areas as a way exactly to try and maximize the minimum volumes that we have, or the limited supply that we have. And hopefully this document will be available shortly to provide some of that overall thinking.
Thank you, Lara.
Thank you, Lara. I can also reflect on that. So pooled testing can be considered, but as Lara said, there has to be a guidance. I know also, some 2 or 3 countries in Africa that are doing pooled testing. But the most important thing is that your protocol has to be validated, not to risk, false negative test results because of dilution. If I can share you the experience from India, they are doing pool testing, but not for people that have direct contact with COVID cases or those with symptoms. So they do pool testing, generally for community screening. I also, know that some countries have also standardized, the protocol in the lab. Ethiopia is an example. They did a small validation work in their lab, and then they are planning to pool maybe 4 samples together and then do the testing. So I think guidance is important, but also labs should do also their own, mini validation of the protocol. But generally, as a concept, it can be done.
Thank you, Yenew. I'd also like to add that for those that have received the package of the recording, the slides, as well as the question and answer from the discussion in the last session, we also had a similar question. And in that response, we have also quoted a few published studies that have done pooling. And it also speaks to what Yenew is talking about in terms of using the right protocols. Thank you. Moving on to the next question, is still around the issue of pooling as well. But this one is from Vinny, who says, what is your view on pooling, knowing that the rate of COVID-19 positivity is very low? So she is bringing the concept of the low positivity.
Yes. Go ahead, Yenew.
It is the same. It's the same concept. As long as you have, the more negative your cases are, the more pooling makes sense. Because if positivity is high, therefore pool testing, you go back to again individual sample testing. But if your test is mostly negative, then pool testing will be really, a recommendation. But as I said, we need to develop a protocol within the lab so that we don't risk, false negative tests because of dilution factor.
Thank you. Thank you. Let me take the next question from Alemwek Adugna, who says the most difficult supply chain management is inventory management of those products used for both HIV viral load as well as COVID-19 tests. So how can we identify and track which products is used for which test at testing sites since the funding source are different? Interesting perspectives coming through when we speak of integration of testing and things like that. What are your thoughts? I'll repeat the question. He is talking about how we can identify and track which products is used for which test at testing sites since funding sources are different. Any comment?
I suppose I could jump in. I see Yenew's on mute. I mean, I think my sense is that that could be somewhat context specific and would really depend on each country and how they develop their inventory management there, as well as, but I suppose from our end, whether it's on the HIV side or the COVID side, would really encourage working together in an integrated way to try and share the technologies. But of course, that will require a fair bit of operational work to ensure that you know, there can be collaboration and financial support across the board, whether it's the same source or not.
Thank you, Lara. Yenew, you want to jump in, or it's fine?
No, I think that's fine. I'm in line with what Lara is saying. Yeah.
All right. Of interest are quite a number of questions that I know Lara's one of the slides touched on biosafety. Biosafety requirements for POC testing need further discussions. And these questions are quite a number. They keep on coming. I've also seen in the chat box, I think I've seen also responses from fellow participants. Thank you for that. We have quoted the recent WHO guides with talking about biosafety and POC. Maybe Lara, you want to comment on that?
Yeah, I think, and we're happy to share the updated guidance that came out last week. But from my understanding of this, you know, I know previously we had suggested that a BSL-2 and a biosafety cabinet should be considered for decentralized and for point of care testing of COVID. But the updated guidance that came out last week should hopefully clarify that those stricter requirements are perhaps not necessary. Of course, countries will be encouraged to do their own risk assessments and to understand their own setting and whether that is the right process. But from our end, you know, the need for the biosafety cabinets and BSL-2s and perhaps the movement of the point of care devices to centralized locations is perhaps not highly encouraged or highly necessary.
Thank you very much, Lara, for that. We will also share the links that have been shared in the chat box as well. And then another question, this is from Alex Costa. How does the WHO process for emergency use authorization of in vitro diagnostic work? When do you expect to have antibody-based tests available for procurement?
So good question. I think, you know, I'm happy to share the link. I believe I may have shared the link to the EUL, and they do have some documentation there as to how, what the procedure is. Of course, it's not the same as their normal pre-qualification procedure, primarily with a lack of a laboratory evaluation and the manufacturing site inspection. But of course, that the dossier review that is typically done for the pre-qualification process is continued. However, on the laboratory evaluation space, we are looking to, and we are already in conversations and working with FIND and others who are doing technical evaluations to provide some of that feedback and understanding. So happy to share some of those documents. They have put out a call for antigen and antibody-based tests. I don't know exactly when the first tests might be listed on the EUL, but they are working towards trying to provide that support as well.
Thank you, Lara. There's another question from Roslyn Warutere from Kenya, who says her input is that we need global advisors to organizations donating test kits and other consumables to encourage bundling. This will ease the headache of country logisticians in distributing donated kits. I think Yenew mentioned something along that line. Any comments?
Yeah, I think that's just a comment in line with what I was also saying. It's not only on logistics aspect, but it's also important for the labs to continue functioning. I see some donors come up with detection kits, and then labs don't have extraction kit, then you cannot do the test. So all procurement efforts should look into a complete package that allows testing to happen in the lab. So I think that's what I wanted to emphasize.
Thank you, Yenew. There is Anna Sombong from the Philippines, and she says, how can we avail or partner with WHO for support, especially for PPE?
Definitely. I think we can share some materials. I'll share some materials with Yenew, and then perhaps those can be distributed widely. But all countries across the globe, across regions, are eligible and can access some of these minimum volumes from the diagnostic side, the PPE, and the oxygen. And we can try and provide some of the materials to direct you into the right space in order to start submitting those requests. These are all this process has been relatively recent. On the diagnostic side, this has been over the last week or two, and I believe PPE should be coming on board shortly with working with countries to understand their requests, their demands, and then of course on the supplier side. So I'm happy to provide some of those documents that have been shared with regions and with countries to this group as well.
Thank you, Lara. I have another question from Ramatu Ture, who says, do our country MOHs know about this platform? I assume he's talking about the platform which Yenew mentioned for placing an order. That is, as in-country representatives should we inform them? Do our countries know how to place orders on this platform? Or should our in-country representative be informed? Okay,
thank you for that question. I don't know if there is anybody online from Strive's team. I saw Dr. Precious or Fatoumata or anybody. Are they online?
They may not be able to.
Oh, they may be on mute. Okay.
Yes.
Okay. All right.
Yeah, Fatoumata is here. Yeah, can you explain on that?
Go ahead, Fatoumata.
I didn't hear you well. Can you repeat, please? Can you repeat, please?
Yes, it was a question on whether the countries are aware of the platform that was mentioned on ordering commodities through the Africa CDC.
Yes, if I understand well what you are saying, in Ivory Coast, we have some of the platform. We have Abbott, but I think that there is no supply for Abbott now. But Roche and the others, we have some supplements.
Okay, so Anafi, I think I was referring to another Fatoumata, so it's fine. But okay. in terms of this, the Africa Union procurement platform, as I said, the system will go live. Actually, it will be launched by the African Union current chair, President Ramaphosa, South Africa. So which means that, all heads of states will be informed. There will be an official launching. So all countries will be aware of it. In fact, to test the system, Some countries wanted to go through this system as a pilot. Rwanda was one country that came forward. More other countries are coming. So I think it will be live and it will be announced for everybody.
And then Nafi, maybe just to jump in, for the portal across diagnostics, and again, this is for Africa, but also for other regions. So we also have a portal that has been developed for commodities, for diagnostics, for PPE, and for clinical, where countries can obviously work together. I would suggest either reaching out to the WHO team in country, or potentially, others, your Global Fund, your UNICEF in particular, and they can provide support in terms of how to provide requests within the portal for these minimum volumes that exist through the consortium. Again, I'll share the material on how to do that with Anafi so that can go out more broadly. But essentially what would happen is we're trying to make it as straightforward as possible, where it almost looks like an Amazon request. You can click on the number of tests that you'd like to request and the funding source that will be provided to access those, to buy those commodities. And then the rest of the distribution and et cetera would happen within the portal or within the control tower. But we'll try and provide some materials to help better understand that.
Thank you, Lara. And I also have Belinda online. She has posted a response around the same. Belinda, can you go ahead and further expression?
So thanks, Lara. Most of the countries, or just about all of the countries, have started to know about the WHO portal and have started putting requests in for allocations or their needs for the next 3 months. So it's possible to do that through the WHO supply portal. And if you need any support, obviously you can get in touch with Lara, or you could get in touch with me here. And unfortunately, Amal has had to go from EMRO, but it might be the same for her. But certainly a lot of the country offices know about the WHO platform and are putting requests through there for their diagnostic reagents. Thanks, Anafi, for letting me speak.
Thank you, Belinda. And just to make sure that we are clarifying, there's a question from Peter Boras in the chat who just wants to know, is this AU ordering platform separate from the WHO one? He feels that might create confusion. So maybe it's best to clarify. Is it the same?
Yeah, Anafi, this came on the direct order from the heads of state. It was actually an order from President Ramaphosa, the current AU chair. So they gave the task to Strive Masiwa and his team to come up with a procurement platform. And they have linked this with Exim Bank, which means that member states will put their money, their budget on Exim Bank, and then list of all companies will be populated. There is also logistics providing companies like Airlink and other airlines included on that. So this is a very huge undertaking that's directly managed by the AU chair. So I think it is completely different from what WHO is. It can be, there can be redundancy, but this came directly from really the request from the heads of state.
All right.
So, can I ask a question? Is it for all items all items including the COVID diagnostics, or just items surrounding COVID diagnostics? Like, does it include consumables and things like that as well?
Yes, it includes PPEs, lab diagnostics, other medications, everything.
Okay.
All right. Thank you. We're glad to know that I think there are platforms to make sure that we are procuring this in a coordinated fashion. So that's good to know. I think moving on, there are some questions I think that are very important, may not necessarily be directly related to maybe supply, but they came through, I think, in one way or the other within the the presentation, and they touch issues around safety. So maybe we could touch this one from Kudakwashe, who says, Lara, the WHO should make a recommendation for use of transport media that inactivates samples at the point of collection to reduce risk during processing. Kindly comment on this in the light of the coming in of the POC recommendation where BSC is not available.
That's an interesting suggestion. I think we would want to really better understand the information and the data that might exist around the need for that. I suppose a couple of things initially come to mind in the sense that I think we'd want to be cautious to recommend that that type of vial transport media be used, particularly as understanding whether those exist already and what some of the volumes are to ensure we don't minimize access to what already exists and the current testing. And then I think, you know, it might be prudent to also suggest, and you saw some of the volumes that are available from, in particular, some of the more near point of care technologies. I know that it's a very exciting opportunity and potential intervention for this assay, but it's unlikely to perhaps provide complete support for countries to meet their entire demand. And so while, you know, this is something that would be useful, the volumes currently available to all low middle income countries will be fairly low. And so we'll want to ensure that countries think about perhaps taking a multi-pronged approach where laboratory-based testing, at least right now, is a key component of that until we can access additional volumes for some of those near point of care technologies.
Yeah, thank you, Lara. There is one or two more questions that we can take before we go. And I see one here from Khalifa Mane says, how can we empower the private sector to support testing in member states? Are biosecurity consideration important for this? I think it's similar to what Yenew had mentioned, that I think the task force was set up for the private sector. So I think that's a possible response to that as well. Okay, I think questions keep on coming, but they are really coming back to issues of waste management. And from the way it looks like, I think we still need to go back to this subject and talk about it. I can promise you, I think within our plans for the next couple of sessions, one of them is going to talk about sample referral systems. And in there, I think these questions will be very relevant, and we would like to also touch on that as well. I know we are almost on time, and I would like to ask Lara in 30 seconds to just give some remarks.
Sure. First, I just want to thank you, Anafi and ASLM, for the opportunity to speak with this significant call. And thank you for everyone for listening. I think this is certainly an initiative that we're very passionate about. We understand the urgency to try and get swabs and tests to countries, and hopefully at least providing some minimum access to all low middle income countries may be helpful for your countries. And hopefully we can work together to ensure that the needs and the demands are being met in your settings. And so please feel free, as Belinda mentioned, to reach out to herself, to Amal in Northern Africa, as well as myself. And we're happy and willing to very much to work with you in order to make this a reality.
Thank you, Lara. Yenew, 30 seconds.
Yeah, thank you, Anafi. Thank you for coordinating this very, very important session. You know, the testing, the scale up in the continent is very encouraging. I would like to thank, you know, the hardworking people in all of African labs and all the partners that are supporting the labs. I think it's really, a remarkable progress. We were less than at 200,000 tests in end of March, so now we are at 1.6 million or so. But I would like to emphasize that, testing should not be done for the sake of testing. There has to be, use of every positive test for really, contact tracing and isolation of cases. It is when we do this that, we can control this pandemic. And then I also urge, really countries to come forward, presenting their testing projections and quantifying all the necessary items, so that it is that way that countries also get supported. I found really, this session to be very, very helpful. Thank you for the good work that ASLM is doing. Thank you.
Thank you, Yenew. Indeed, I think this is very, very helpful, very informative, an important subject indeed. Whilst we are talking about testing, it speaks to the issues that we have already talked about, result utilization, and it can never be overemphasized in such a scenario like a pandemic, where a result is really needed for the control of the disease. This speaks to what we are planning to speak to in our next monthly LabCorp session, which is coming this Friday. How can we expand this testing to sub-national level? We know most of the time testing has been happening at national level, but if we need timely results, how do we integrate what we have? There have been so many questions around point of care, so many questions around safety. How do we interact this in an optimized way in order to save the population that we have using existing resources? So please join us on Friday, where we discuss further these issues, as well as upcoming sessions as well. For now, goodbye, and thank you for everyone for joining. Bye-bye.